Hello, Andrei Pop here, moderator of the Aortic channel on Murmur MD, here with Keith Allen. Keith, I think, needs no introductions. He has been with us before. He is truly one of the luminaries in the field of alternative access for TAVR, and he has published extensively on transcarotid TAVR as well as surplus and other let's say, TAVR accoutrements. And we're delighted to have Keith here with us to talk about transcarotid TAVR. Keith, welcome.
Thank you, Andrew. Appreciate the invitation.
So, when we started doing transcarotid TAVR, we all felt kind of it was crazy to go for the carotid, to put a big valve in the heart. We're so scared of the carotid. We're so respectful of the carotid. But it turns out to be, I think, for most people, the preferred alternative access. Tell us more about why you like carotid so much and what makes it so safe.
Yeah, so this all started back we did our first transcarotid in 2015. And, I'm boarded in vascular surgery as well as cardiac surgery. And there had been a couple of cases that had been reported and people had kind of dabbled with it, but they did it in a very complicated fashion with patches and shunting and so forth. And it became really apparent to me that we could do this pretty straightforward. And obviously the Medtronic platform was all axillary, and the Edwards platform was either, primarily transapical or direct aortic or axillary. But this allowed either device to be done with carotid, and we published and presented it, what was then TVT, in 2019. And, carotid was a little blip, and we compared it to intrathoracic, and it obviously trounced that. In retrospect, that was a no-brainer. And from there, it just took off. It really then took off when we looked at using both Medtronic and Edwards, comparing it through the TVT to axillary. And what was concerning there was the stroke rate and mortality was higher with axillary, much higher compared to carotid, which, as you in your introduction, it seemed counterintuitive that was the case. But from that point on, carotid is now close to 70% of all alternate access done in the U.S. There's still some axillary. There's 2 or 3% use of transcaval. There still is some transapical being done. There's a smattering of other, but carotid has taken off. And it's all driven by how easy it is. The carotid is exceedingly easy for even the average surgeon like me to expose. Much easier than the axillary. Plus, it's a very robust artery. It's a thick-walled, rubbery artery. It's not fragile. And then it gives really direct access down into the ascending aorta. So it limits the wire interaction with the arch. And obviously, unlike, transaxillary, you're not crossing vertebrals when you're passing these large devices. And then finally, it's the cheapest embolic protection there is, because when you're doing it, you're occluding that hemisphere of the brain. So it's got a lot of positive attributes that has nothing to do with me or even other people that are promoting it. You know that any procedure that takes off and becomes democratized and popular does it because it's easy, simple to teach, simple to learn, and inexpensive, and gets good results. And carotid does all of those things.
So, do you think, you mentioned at the beginning that you're double boarded, and a lot of the surgeons, let's say, before this generation, did that, cardiac surgeons. But a lot of people coming out of training now are no longer boarded in vascular. Vascular surgery has crowded them out of the carotid space. I hear of places where they need a vascular surgeon to help with the carotid access. How prevalent do you think that is, and do you think that's something that we're going to see more of as younger surgeons come into the field?
Well, I think that's a really good point, and I think that's probably the biggest Achilles heel of carotid access. But having said that, most young surgeons coming out are pretty facile at doing carotid subclavian bypasses because they're involved in TAVR and covering the left subclavian. So exposing the carotid low in the neck, which is where you expose it, is actually, for even a younger surgeon, not too terribly difficult. I think what scares them is when you talk about carotid access, they think you're working high up in the neck like you would for a carotid endarterectomy. But, you don't even expose the crossing facial vein. You're certainly nowhere near the bifurcation when you're doing carotid TAVR. It's all very low. But that is a good point. And I have proctored places where the local politics, and as we all know, politics is all local, they've had a vascular surgeon come in and expose the carotid, and then the cardiac surgeon and the IC kind of take over, and then the vascular surgeon closes it. Interestingly, those places that have done that, they do that for a little while, and the vascular surgeon loses interest, and then it ends up just being the same heart team doing it. But, that does happen.
How about monitoring? Do you monitor cerebral oximetry? Do you monitor EEG? What do you monitor?
Yeah, great question. So I used to do, when I did a lot of carotid endarterectomies, I did all my carotids with EEG monitoring. And so when Adnan and I first embarked on this, we said, well, we'll do the first 100 cases with EEG monitoring. And we only had 2 instances where, while we were clamped, we had a dip in the EEG on the side that we were clamped. And in both of those cases, it was because we were hypotensive. So we've never shunted a case until recently, and I can tell you about that case, but I've never shunted a case personally in over 300 transcarotid TAVRs that I've done. And all I do is raise the pressure. So it's important that you have a systolic pressure 140, 150, and that, the patient's on a drip. So if they've got good LV function, use some levo or norepi. If their function is bad, put them on some epi at the get-go of the case to start getting their pressure up. You don't want anesthesia giving boluses, because then you end up on this roller coaster of pressure. But right now we don't monitor at all. And then, the workup for carotid is very simple. Everybody, thought you needed to do, prove an intact circle of Wildis, or do, angiography of the brain, or do dedicated TAVR, dedicated CTAs of the neck. You need absolutely none of that. All you need is a carotid or as a TAVR CTA and a carotid duplex. So most of our TAVR CTAs go 2 or 3 centimeters above the clavicle, which is where you're accessing, and that's all you need. And then you need a carotid duplex, because a carotid duplex guides you to the side that has the worst carotid disease. So it's counterintuitive that you would access the side with the worst internal carotid artery disease, but it makes sense. That's the side you're going to be occluded. So you want the contralateral side to be open and lots of good blood flow.
And a lot of people I hear saying, oh, the carotid is too tortuous to access. The surgeon that I work with, Bob Kummerer, tells me that, once you've exposed the carotid, you can pull on it and it straightens. What is your experience? Are you worried about tortuosity? Because, back when I was doing carotid stenting, I was told tortuosity is okay, calcium is okay, tortuosity and calcium together are not okay. So how do you tackle tortuosity?
Yeah, so you've got a good surgeon, because what he says is absolutely true. The carotid is a soft, very thick, very rubbery, mobile artery. And if you just look at in the next 10 cases that you look at for TAVR, just scan up and look at the carotids. It's amazing how they can have horrible iliofemoral disease, and you look up at that proximal carotid, and it's, has no calcium in it at all, and it's a huge vessel. And if you just look over at the subclavian or axillary, it's horribly diseased. There's something about that vessel that, is somewhat protected from calcium. But it almost always straightens with just a extra small safari. We rarely, if ever, have to put a stiffer wire than that in. And that's our workhorse wire.
How about, do you ever find yourself in situations where you have to do something to the ostium? Because that's where you sometimes see big plaques.
Well, so that's another good question. So that going in because you can look at the CT and you kind of get a feel for that. It is important that when you put your sheath in, that you take the sheath down into the arch. So you want to bring your valve out. This is taught about in Edwards. I'll tell you about Navitor or Medtronic. But when you're doing an Edwards, you want to take the sheath down to and just into the arch. Flower the valve out into the arch, and then you can pull your sheath back. That's really important when you're using Certitude, which I actually prefer. If I'm doing an Edwards valve, I prefer to use Certitude than Commander. And the reason for that is that while Certitude is either an 18 or a 21 French, it allows you to have the balloon already mounted. You don't have to mount the balloon with your nose cone across the valve. And it's ergonomically using the Certitude sheath, it's a short sheath. So it's hugely favorable over Commander. But what you do lose is if you've got a circumferential area of calcium and you're using Certitude, you don't have a pusher rod anymore and you lose pushability. So with Commander, you can kind of muscle your way through lesions. You can't do that with Certitude. When you're using Commander, we did a case earlier in the week with Commander because the artery was 4.5 millimeters. And, you're not going to put an 18 French through that. If you're using Medtronic or Navitor, you can use the inline sheath, which is, 14 or 15. But I find that very cumbersome to work through or not, you don't have a sheath. So if you're doing hemodynamics, if you want to do pre and post BAV, things like that. So I typically will use a Cook 13 centimeter long, 18 French sheath and work through that sheath. What I did early on in our first 70 cases, I used to cut long sheaths, including the Commander sheath because I didn't have access to Certitude. But I don't do that anymore. I just either use a short sheath or use Certitude.
Do you ever use dry seals? Because a lot of places, I know some places have used dry seals.
Dry seal's great, but dry seal doesn't make a short sheath. So
right.
the dry seal sheath is very long. And the other thing about dry seal, if you want to cut that sheath, you can't cut a dry seal because it's wire reinforced.
Right.
The only sheath out there that really cuts well is a Cook sheath. And a Cook sheath you can cut if you wanted to shorten a long sheath.
And what's too small for you? You said you went through a 4.5 millimeter.
Yeah, I'll drive an 18 French sheath through a 5 millimeter carotid artery that's not calcified all day long. It just gives. And it's very, very different than, an iliac or a femoral. That doesn't give and certainly won't give if it's got, even a modest amount of calcium. So, and Commander, if you're using a 14, 16 E sheath, then, you can put that through a 4.5 millimeter vessel.
Some people will push the sheath pretty close to the valve, will advance the Sapien valve all the way and prep the valve inside the sheath. Any advantage to that, or?
Yeah, I wouldn't recommend doing that.
Okay.
So I would recommend flouring the valve out and pulling your sheath back a little bit. So you want the valve to self-center, and obviously when you're deploying the valve you're going to pull it back, but what you don't want to do is have the sheath in the ascending aorta when you're deploying any of the platforms, because they won't self-center and they won't move the way you want them to. um, but even mounting the balloon, so it's really pretty, I mean, it's pretty hard to mount the balloon in a commander sheath, because I mean that's how they got it to be 14 to 16. So you can use the other sheaths, but ergonomics then become bad. So you're working with a device that's meant to go from the groin and up in the neck. It's not impossible. But if the one time, if you use Certitude, you'll never go back unless you have to because of size.
Um, it's interesting. I recently did within last month or so, we did our first transcarotid leaflet modification. We did a unicorn, and I have to say it felt like the easiest procedure I've ever done for leaflet modification. I mean the the axis is so perpendicular to the leaflet. You get away from using AL catheters, you use a multi-purpose, and it's super easy. And I'm wondering whether carotid in the future will play more of a role as we're messing around with the leaflets.
Yeah, so it's interesting that I'm going to have you talk to Adnan. So I pushed for carotid for our leaflet modification, and we've done one, and it went very well. We've not done a unicorn through the carotid, but the you've got such one-to-one delivery. You're this far from the valve, and you just can move things so easily and manipulate things so easily with carotid. There's no stored energy, none of that. And so I think it does lend itself to, you know, complicated procedures.
How about left carotid? Because a lot of people are kind of afraid of the left carotid due to ergonomics and room setup and all that kind of stuff.
Yeah, so we're an equal opportunity carotid abuser. So in our series, it's about 45% left and about 55% right. So we pick the carotid. If all things are equal, we pick the carotid that takes you into the ascending aorta. So if you look at your do a coronal reconstruction and look at your brachiocephalic vessels, you'll see the tortuosity and the direction. Sometimes you have a right that takes you down into the mid or distal arch and it dumps you into the descending, and you're doing this, whereas the left takes you right in. We also think that if we're going to go right, we prefer to use a balloon expandable. It's not that you can't use Navitor or Medtronic, but what we found is the balloon expandable valves don't self-center as well when you're coming in from the right. You come in from the left and they tend to hug like they do for transfemoral. When you come straight in from the right, um, you lose your parallax or orthogonal nature to the annulus, and they don't tend to right or self-center as well.
Yeah, so if you have a self-expanding valve, you prefer to go from the left, if at all possible.
If we're gonna go if we're gonna go left, we can use any platform.
Mm-hmm.
If you're gonna go right, we would prefer to use a balloon expandable platform.
Makes sense. Um, so it's interesting. I had a case that they sent me yesterday, and the Edwards rep was really worried because there is a pretty significant dissection right distal to the left subclavian. it's not a long dissection, maybe 5 centimeters of the descending aorta is dissected. And I said, it's easy. You go right carotid and we call it a day. Why struggle? And they were really worried about whether doing something in the arch could extend the dissection. And I said, no. Coming from the groin could extend your dissection. So I think it's one of the learnings that I think we both agree on is that whenever you have difficulty in the descending thoracic aorta, in the abdominal aorta, the carotid these days, it's such a standard procedure and such an easy procedure and such a low risk of stroke that I think it should be the default for difficult access.
I mean, I responded to a recent post on Murmurs, which I love this site and it's great. But I responded to a recent post, and anytime I hear people perseverating about femoral access and do I need to shockwave or should we, crack and pave, or might I need to pre-dilate, or do we have a dissection, or can I get through that iliac stent? Any of those discussions for our team, and our cardiologists are the first. We don't do that. We just default to carotid. So, I mean, if it's not a routine transfemoral and there's a risk of having a complication transfemorally, why would you do that if you're comfortable doing a safe, quick, alternate access like carotid?
One of my mentors taught me the KISS technique, keep it simple, stupid. So
it's my favorite word.
The older I get, the more I believe in that.
Yeah, that is, just absolutely the truth. But unfortunately, some programs, when I hear somebody at a meeting talk about the extraordinary, I was at a meeting the other day or a couple weeks ago, and a case was presented where they actually did staged peripheral vascular interventions. They brought the guy in and stented and opened and did all this, and then they brought him back and did his TAVR, and they did all that just so it wasn't even symptomatic from his PAD. And you go up and look at his carotids, and he's got 8mm big juicy carotids, and it just, just keep it simple, fix what you need to fix. But that was a team that they didn't have a surgeon that was engaged. And this is why it's, you're fortunate. You've got surgeons. We've got our program where surgeons are engaged and are comfortable with TAVR and comfortable with mitral procedures. And, this is why it's so important to have a good heart team where you've got a surgeon, you've got a cardiologist that talk and communicate and are on the same page. Because we do a lot of things. I do a lot of things as a surgeon that I wouldn't do if I didn't have Adnan to bail me out. And Adnan is willing to do a lot of things that he wouldn't normally do because I can bail us out. And together, it's a nice team, and that's really what you need to strive for.
Well, I think that's this may not be what people want to hear, but when people talk about single operator TAVR, that's the problem. I think, you and me and, many others on both sides of the table can do TAVR by ourselves. But I think in the end, the patients are much better served when you have a team taking care of you. And as you said, if you're not able to do transcarotid access, you will perseverate and try to get some sort of crazy peripheral access and do procedures and increase your cost and have complications and whatever. If it's an easy solution, just go with the easy solution.
Yeah, totally.
So why do you think subclavian has this high stroke rate, which is pretty consistent across a range of studies? I mean, clearly more than carotid, clearly more than transcaval. What do you think it is? Do you think it's the lack of protection? Do you think it's just excessive manipulation? What is it?
Yeah, I think there's a couple reasons. I think the one is the wire interaction. So there's a tremendous interaction when you go subclavian to get into the ascending aorta, much more so than when you're coming transfemorally and you're doing a gentle curve, or when, so that's one. Two, you're crossing a vert. And, we know that, if you don't, that vert has a stroke risk to it. And, that I think the final reason is that when you're doing carotid, you are clamped, or at least you should be clamped. You shouldn't be doing carotid through purse strings and dilating. You should be doing carotid through an arteriotomy, and you should be clamped. And if you don't do it that way, your stroke rate's high. So you should be doing it that way. And carotid allows you to have embolic protection during the case.
So when
For
you
that
say clamp,
hemisphere.
when you say clamp, you're talking a clamp of the artery, or do you rubber loops and all that?
No, not rubber loops. So when you do a carotid, you should put your 6 French sheath in, cross the aortic valve just the way you normally do, put your stiff wire in after you do your hemodynamics, and then you put a clamp distal up towards the head, and you wrap a umbilical tape around your 6 French proximal. Take your 6 French out, snare your umbilical tape down so it's not bleeding, and then you make a transverse arteriotomy incorporating that stiff wire. So you actually have a hole in the artery. It's not a dilated hole, it's a surgical arteriotomy. Then you bring your sheath in, all of that's bloodless, do your TAVR, and then you bring your sheath out and you primarily repair that arteriotomy surgically so that you don't have narrowing, you don't have a deformed or damaged vessel. It's surgically repaired and inspected, and then you de-air and flush any potential embolic debris, and then you take your distal clamp off and reestablish blood flow to the brain.
How often do you have to patch it or do more of a repair than just standard?
Very rarely. In our series, it's probably less than 2%. The most common thing you have to do, which is why it's important to do an open arteriotomy, is you've got to remove some debris, or you've lifted a plaque where you've put the sheath in. And when you're not doing an arteriotomy and all you're doing is putting a purse string suture the way you used to do it when we did cut downs on the femoral artery, you don't see that, and that causes problems. So
how about neck hematomas? Some people put JP drains and leave them in for 24 hours. Any point in that, or?
Well, no, not really. So drains don't do anything for the most part. They treat the physician that puts them in. But having said that, I've never drained carotids in the last 35 years. Drains really don't protect you. If you're going to have bleeding, they clot off and got to go back. So, you count on one hand the number of times that we've had to return somebody to the operating room because, they've developed a hematoma. I won't say it never happens, but it's very unusual, and we don't drain the patients. So.
How about the other complications that we were used to seeing with carotid and arterectomy, nerve palsy and stuff like that?
Great question. So the beauty of this is that you're working low in the neck. So you're not up by hypoglossal. You're not up by glossopharyngeal. So you could injure the vagus. You'd have to work really hard, though. The vagus in the lower neck is a big vessel, or is a big nerve. And it's usually in the sheath. As long as you stay on top of the artery, that's going to get swept away. You could injure a non-recurrent laryngeal nerve. That can happen anytime you make an incision in the neck, but that's exceedingly rare. So cranial nerve injury, because you are so low in the neck, is, I won't say a never event, but it should be close to a never.
Cool. Well, thank you so much. So now we know that Keith started doing carotids at age 12 because he's been doing it for 35 years. Uh,
Not quite.
Thank you so much, Keith. Always a pleasure, and I'm sure we're going to have other topics to talk about in the future. So thank you so much.
I love this. I love this app. I love what you've done and your team has done, and I learn a lot by. I usually get on it every time I get a notification. So thanks for what you do.
Thank you. Thank you so much.
Take care now. Bye bye.
Bye.